Thanks for the invite. Thanks to the mHealth Hub colleagues. We have been in very productive touch as well within the joint action supporting the European eHealth network. So it's a pleasure to be here. Thanks also to my Austrian mHealth Hub colleague, Stefan Sauermann, who I believe is here. I'm looking forward to give you a bit of an international comparative perspective here. And my take-home messages for today will be that I think there is a couple of points where it will be very interesting and very relevant to continue an international exchange on this topic, specifically with regard to pricing dynamics, with regard to, of course, quality labels and evidence provision. So there is a couple of observations that we can start with. We all know that mHealth is a booming field. It's a lot of solutions out there. COVID gave the whole system another push. We have seen a lot of initiatives and discussions around the proximity tracing apps, of course. From a regulator's point of view and from a consumer and citizen's point of view, it's very necessary to determine what apps are effective and safe. So there is a sort of assessment challenge. In the last few years, we have seen a lot of good work with regard to these, in a way, health technology assessment-like assessment frameworks for mobile applications. Things started out with initiatives like the MAR scale that was developed in Australia. In the UK, we have assessment standards being used in a lot of other countries and in a lot of research projects. The question is asked, what do we need in addition to the GDPR data protection requirements, for instance? How do we assess usability, possible bias in the in socioeconomic dynamics? There's a lot of different dimensions we could look at. So the question I want to focus on today is not the sort of HTA-like assessment per se, but the reimbursement system. So how do we connect apps to our statutory healthcare funding? And in principle, there are a couple of options, right? So in a lot of countries, we still have the situation that there is no public sector intervention, in the sense that there is no official mHealth app registries, there is no official reimbursement pathways. It's sort of unregulated. It's not unregulated because we have the medical device directive and then the regulation in place, but it's apart from that, it's an unregulated market. Then there is a situation where you can have user guidance, for instance, through official registries or user guidance for health professionals or for consumers. And then we see an increasing number of cases where we have financial incentives for these apps as well, usually starting off with individual payers reimbursing some, and then national solutions like the colleagues from Germany have now presented, where you indeed define a clear, transparent reimbursement pathway. The situation in many countries, including Austria, is that we lack such a pathway. So just to a quick overview over the situation in Austria, we have a couple of public sector innovation projects around integrated care, for instance, where mHealth apps are employed and are in the field. We have a few cases where private sector app developers managed in sort of a case-by-case negotiation with individual payers, with the social insurance fund, to get their app into the reimbursement. And we have a combination of private and public work on the COVID-19 tracing app, which is a whole story in itself that I won't go into. That's basically the components we have, but we don't have this sort of clearly defined, regulated, based on a legal foundation, a reimbursement pathway, like for instance in Germany. So what I want to do here is to look at some interesting country cases that then help us to draw some conclusions for the international discussion. Now, luckily, we had our two excellent speakers from Germany already, so the very interesting German case is covered already in much more detail than what I can present here in the other cases. But I want to quickly look at Belgium, England, and France. I will then present one approach. There are, of course, many, but one approach towards systematizing a bit these different reimbursement approaches that we see, and discuss what we can learn from these cases for our discussion at the international level, but also for discussions at the national level in countries like Austria that are deep into the thinking of how we move forward in regulating the mHealth space. So the way Belgium addresses the topic is they have, via the mHealth Belgium platform, established a pyramid-like three-level stage process where app developers can apply to be listed at a certain level of sophistication, so to speak, where the first level is that the app developer drops the application and basically states, look, we have this app, it's CE certified, and it's GDPR compliant. This is checked, and then you get listed as a level 1 device on mHealth Belgium. If the app developer is willing to, in addition, perform a risk assessment according to standards developed by a Belgium responsible entity, and can showcase we are also safely connected to the eHealth infrastructure, and there is sort of data protection and cybersecurity standards that we meet, you reach level 2. And then there is level 3, which has just now, I think these months, been finished in the sort of spelling it out, regulatory frame. It's reserved for apps where also the socioeconomic added value has been demonstrated. So you have to provide evidence for the effectiveness of the solution. And then this level 3 achievement goes along with automatic reimbursement through the statutory social insurance. So as per January, 23 apps are at level 1. 7 of these are also at level 2, and 1 has reached level 3 and is being reimbursed already. It's hip knee rehab application. The process looks like that for the level 3, that at the NIHDI, which is sort of the umbrella organization of the statutory social insurance and health insurance, there is an application, a working group is set up. The working group gives the recommendation to the insurance committee at the same institution, which takes the decision on the reimbursement. The situation is different in the UK, in England specifically. Most of you will know the NHS app library. So this is collecting all the apps that go through an assessment defined by national standards. It's important to note, though, this inclusion in the library does not go along with reimbursement. So what the library aims at is, first of all, to give the consumer and the health professionals guidance, and to facilitate decision-making on reimbursement, which in the case of the NHS system is decentralized. So it's done in local clinical commission groups and NHS trusts. So these can use the app library as a tool, and they can use the evidence standards framework developed by NICE also as another tool for sort of evaluating the evidence that comes in. And it also serves the app developers to know what they're measured against. But the important point here is that the decision-making on the funding is decentralized. It leads to the situation that when you go through the app library, you find information on specific apps that are free for people living in a specific constituency of one NHS trust, but not in another, which is just one way of fitting sort of an mHealth reimbursement pathway to the setup of the health system. In France, to give a third example, it works via inclusion in a broader, not mHealth specific list of products and health services qualifying for reimbursement, the so-called LPPR list. There is evidence requirements specified by the Haute Autorité de Santé, and you can apply and you're evaluated against these standards. There is also a committee-based process, and following this procedure, one or two, I think 2 apps now are already included in this much broader LPPR list, which is basically the list of services and products that get reimbursed. So if you're interested in detail, there's some more pointers here, but I think in the interest of time, I will not go much further into this. We have heard a bit also on pricing from the colleagues in Germany. So here the French case is it's slightly different, but it sort of you see that they have been through a similar thinking process. So the first thing is that the health-related care outcomes affect the pricing dynamics. So if you are able to justify superior health-related care outcomes, you go into a different pricing segment with your application than when you cannot. So for instance, if there is the health-related care outcomes are not better, but also not worse, but you can demonstrate that you have non-medical outcomes that are better than the previous situation, you are reimbursed, but you don't get the premium price that an app would get that shows both superior medical and non-medical outcomes. So there is this categorization As we learned from the German case, there is a very similar thinking that has been behind the way it's set up also. And then in a few slides, I will have a bit more thoughts on this question of pricing. So what we, my colleague Dimitro Pantelli and I tried to do is to get a bit of a systematic overview of these different types. And what we argue is that you could distinguish these reimbursement frameworks by these three dimensions. The mode of reimbursement, the unit of analysis that the decision-making hinges on, and the fact whether the decision-making is decentralized, centralized, or mixed. So the mode of reimbursement, for instance, contract-based, is basically you have an app, you find a payer, you have a contract, and you get it into the payment system on a one-by-one cases. Program-based would be if you manage to get into a integrated care program, for instance, and as part of the integrated care program financing, your app is funded. Catalog-based is if the app is included in a broader reimbursement catalog, and registry-based is the situation that, as we've seen it, for instance, in Germany. So you can classify these examples and see, for instance, that Belgium is a registry-based system looking at individual applications with mixed and conditional decision-making. Decision-making is mixed and conditional because it's only centralized when you reach level 3. That's why this is this mixed conditional category. In England, you have also registry-based individual application decision-making, but the decision-making is decentralized. In France, you have this catalog-based, not mHealth specific registry-based mode of reimbursement, also looking at individual applications, and the decision-making is centralized. And in Germany, you have a registry-based mode of reimbursement, central decision-making, and a very interesting combination of the unit of analysis. And maybe if you're interested in more detail, and the German colleagues are able to explain that much better than I am, but as far as I understood, you of course apply to the BfArM with your individual application, but the legal basis for the registry knows functional and target group specific groups of applications. And these groups of applications can play a role in pricing when additional apps come in applying for reimbursement that try to offer the same services. Because it's a very interesting pricing question, how you deal with not only the first app in the field, but the second and third app trying to do the same thing. And maybe doing it better or doing it worse, but you don't know. So you can't really, you have to find a way. So this is for your reference. This will be in the documentation. This will be shared, but we tried to work out the advantages and disadvantages of the different types from the perspective of the producer, of the payer, of the physician, and of the system. And just one spotlight that I think is interesting in the discussion today, from a producer's point of view, if you have centralized decision-making, you have less workload for market entry because you have one entry point, but you also have less room for negotiation. And I think this is an interesting aspect to keep in mind when we discuss the international field, which is what I want to do in the last 2 slides. So I think there's 5 key questions that we can formulate. One is, of course, what is the evidence required and who is paying for the evidence provision? In the German case, for instance, please correct me if I'm wrong, but if you are first with the first developer offering an mHealth app with sort of a new type of intervention, there is the opportunity that you get a sort of innovation add-on or premium price because you are the one that first has to demonstrate that such an intervention is effective. Whereas the second or third comers might rely on the studies you co-funded and use that to demonstrate that the intervention principle works, right? A second key question is how to set prices, and there's a lot of options. Fee for app, fee for subscription. Do you have maximum prices? Do you have thresholds? How do different types of effectiveness affect the reimbursability in pricing? Point that we have seen in the French case. Third key question is there a need to regulate or limit market entry? What do I mean with that? The question is, if you take the example of medication diaries, there might be, and we in fact know that there are in certain app cases, a lot of solutions trying to do the same thing. Now, do you offer reimbursement to all these solutions, or do you cut off at a certain point? Or how do you deal with the pricing in that case? If you have 15 apps and one comes first and gets reimbursed, and then you have 14 others saying, okay, we're doing the same thing, we might do it better, we want to get reimbursed as well. And it creates sort of work, right, to process these applications. in terms of the international dynamics, what I find a very interesting key question: what does a market entry of an app in Germany do to the application's pricing model in another country when they hit another market? And finally, what are the options for international cooperation? We might look at these questions again in the discussion if you're interested. So the key message is, I think, is we all know there is inevitable differences in the reimbursement frameworks simply because our health systems are different. But what we can do and need to do internationally is, I think we need an exchange about best practices with regard to quality criteria, and also how we deal with linking requirements for market access and reimbursement. We need to think about dynamics in pricing, a bit like in the case of medicinal products. So there is a potentially intransparent market there in medicinal products, and there are frameworks built around mitigating that. And I think we have to figure out in how far the mHealth space is similar to that and different from that, and what we need to do to ensure sort of fair pricing for all parties involved. And finally, we might to think about something like mutual recognition of reimbursement decision-making. And there might be sort of differences regarding the user base, right? So we from Austria, of course, are thinking an app, a German-speaking app that's reimbursed and has gone through the process in Germany. Why don't we recognize what they have providing in Germany and what Germany's decision-making was on that app from a Swiss or an Austrian perspective, where the app would be in the same German-speaking version might hit the market, right? And then there might be other apps that are oriented more towards an EU level market. So this is things I think we need to think about, and we need to continue to be in collaboration. And that's it from my side. Thank you very much. I look forward to your questions here, or feel free to contact me also on other channels. Thank you.